Hello. I am Tom Farrington, President and founder of Finn, and it's so good to see people here at Dana-Farber today in Boston. We had a spring day in Boston, and it is so good to wave to all of you who have joined us online. Some of you may have beat us to spring, and some of you may be lagging, but I think the good days are coming. So hello to all, and as we spring forward, as you might say. Tonight, we have a program that I think will be relevant to many of us. We're going to talk about recurrent prostate cancer. We're going to talk about clinical trials, and we're going to hear some patient stories. This is my 24th year as a prostate cancer survivor. I had my first treatment in the year 2000, and it was not the only treatment that I had. So after I had my initial treatment, I did have a recurrence of disease. And so therefore, I was back out looking for another treatment. And that was 9 years after my initial treatment. So, and I know that many other prostate cancer survivors and many other families face the same challenge that I did at that time. How do you deal with it emotionally? And what are my treatment options? And finding those treatment options and the right one are as important as finding that initial treatment option. So we're going to talk about that today. Now, to help something that we did not have when I was diagnosed, we did not have finpath.com, which incorporates the NCCN guidelines on treatments available following surgery and or radiation. So Dr. James Smith is going to talk to us about that. Dr. Keith Crawford is going to then talk with us about clinical trial options. Those are other treatment options during this phase of prostate cancer journey when you have recurrence. Are there clinical trial opportunities, and what could some of those be? So Dr. Crawford will spend some time talking about that. And following that, we have two patients who are undergoing, who are survivors. One who has recurrence disease and had to find another treatment. The other one looking at treatment options now and doing testing. So all of these experiences, all of these options are very germane and important in a patient's prostate cancer journey. So we're excited to bring this information to you this evening. So at this time, I'm going to ask Dr. Crawford to come and introduce our first speaker, Dr. Jim Smith. Dr. Crawford.
Good afternoon, good evening, good afternoon, everyone. Thank you, Tom, for the introduction. It's very important that we want to deliver a message that once you're diagnosed with prostate cancer, it's not over. Your journey changes directions, and you have a journey about managing or how to manage prostate cancer. So, but first, what we want you to know is if you have prostate cancer and it comes back, you have treatment options that are available. Now, Dr. Smith III is going to talk to you about prostate cancer treatment options that are available when the cancer recurs. So, James?
All right, very good. Thank you, Dr. Crawford. Thank you, Tom, and greetings to all. I also like to thank our sponsors because the sponsors are really which allow Finn to bring this important information to you. As Dr. Crawford has said, this evening we're going to review treatment options when one is given the news that there's a prostate cancer reoccurrence. We will review the next steps and treatment options, whether one has had surgery or radiation therapy. First, allow me to give a shout out to early detection. Remember, early detection saves lives, so that those in attendance, a yearly screening is a must, and it still includes an annual physical, a PSA blood test, and a digital rectal if advised. Also, as you heard Dr. Crawford say, once you've been diagnosed with prostate cancer, ongoing follow-up and screening is a must. We will never let our guard down as we are living with prostate cancer, and we keep that not in our everyday thinking, but we keep it so that we're aware of the importance of ongoing follow-up. All right, so when one is informed that there is a reoccurrence, what do we do next? However, before we talk about that, the diagnosis to that to be made, that the physician, your clinician, has to run several tests. And let's start by explaining what these assessment tools are. Obviously, the first tool is the PSA blood test. As a reminder, the PSA is a measure of how much PSA is in the blood system. For many after surgery or after radiation, the PSA is either undetectable or 0.1, give or take. However, we concern ourselves with the rate of change of the PSA blood test from right after treatment to your next follow-up. Follow-up could be 90 days. Follow-up could be 6 months. That's a decision that your clinician will advise you on. But one would expect minimal change at all in your blood test. And if the change is more than 10%, we call this a velocity. This change in a velocity of the PSA will set off an alarm. The second set of tools are imaging tests. These tests take pictures of the inside of your body. These tests are used to detect and treat prostate cancer, and your doctor has multiple choices. One choice is a CAT scan, and we take he orders a CAT scan of your abdomen or your pelvis, and it's looking for a cancer, and it's also looking for a cancer that is spread to other areas of your pelvic area, and we call this metastasis. A second tool is the MRI. An MRI is where a contrast material may be used to make the pictures clearer. Currently in use is a special type of MRI called a multi-parametric MRI scan. This scan is done before a biopsy to learn more about your prostate cancer and to look for prostate cancer that is metastasized to nearby lymph nodes in your pelvis. Thirdly, we have PET scans. A PET scan is usually combined with a CT scan or an MRI. This combination, however, is used to look for small tumors, metastasis of soft tissue or bone. And finally, we have a bone scan. And if you have a bone scan, most patients have bone pain. And this bone pain will put them at high risk for bone metastasis. A bone scan can also be used to monitor treatment, all right? And this is very important. A bone scan uses a radial tracer to make pictures of the inside of the bones. Before the pictures can be taken, the tracer will be injected into your vein. Then it takes a few hours for the tracer to enter your bones, and a staff will use a special camera that will take pictures of the tracer in your bones as it moves over your body. The scan will show areas of bone damage as they use more radial tracer than healthy bone, and they will show up as bright spots on the pictures. However, bone damage can be caused by cancer, cancer treatment itself, or other health problems. So before you, as you see on the screen, Finn has put together a Finn path, and we are under the tab of Finn path treatment pathways. And now we're going to go to PSA reoccurrence after radical prostatectomy. Remember, for patients with a PSA biochemical reoccurrence after prostate removal through surgery, these are the treatment options. We divide it into two categories, one with no distant metastasis and one with distant metastasis. We also, as we've talked in previous sessions, life expectancy plays a huge role in your decision making about treatment options that are best for you and your situation. If one has a life expectancy of more than 5 years and the studies are negative for distant metastasis and or a pelvic reoccurrence, EBRT or EBRT and ADT are preferable. We also, during this time, obviously, we continue to monitor for pelvic recurrence via biopsy, right? But if that biopsy is positive, whereas if the biopsy had been negative, with a positive biopsy, we're looking at EBRT and ADT, EBRT and ADT and albuterol, and EBRT with albuterol, and excuse me for not pronouncing it correctly, but it looks like Yanza, all right? So we have these options available to us with no distant metastasis. As we scroll down to distant metastasis, our options become the following two: EBRT with androgen deprivation therapy, or ADT, EBRT and ADT, along with the two types or either one of the albuterols. However, if a life expectancy is 5 years or less, some may choose of monitoring and following up with your physician every 6 to 12 months as needed, and may decline the above treatments. However, Finn and NCCN, we've always said we believe that the best management of any patient with cancer is to be in a clinical trial, and participation in clinical trials is especially encouraged. Now we will scroll back up to the treatment pathways, and you'll then click on cancer progression after radiation. Okay. Again, remember, patients with a PSA biochemical progression after being treated with radiation, these are your treatment options. Again, with no distant metastasis and a life expectancy of more than 5 years, but with a biopsy that is negative. All right. We always remind folks about monitoring, both with the physical and the PSA, but we start with ADT, androgen deprivation therapy. If you have a life expectancy of more than 5 years, but your biopsy is positive, all right, yes, we are monitoring you. Yes, we're doing the physical exam. But at this point, you have other choices. Those choices mark the following 4: radical prostatectomy with pelvic node dissection, cryotherapy, HIFU or high intensity focused ultrasound or brachytherapy. If your life expectancy is more than 5 years and your pelvic reoccurrence biopsy is positive, again, here are your options. Also reminding everybody gets monitored, but you're looking at androgen deprivation therapy, ADT. You're looking at pelvic node radiation, all right? And this is if it had not been done previously, but pelvic node radiation or pelvic lymph node dissection. Life expectancy or 5 years of less, we're at, again, following up. You may choose not to engage with the above two recommendations, but as always, clinical trials are to be considered. And I think it's so important because, as we've heard multiple times, clinical trials give us the best possible care. They're free, and they give you the state of the art, which is so important. So we've covered a bit. Let me just kind of review if I can. Jerry, if you could go back to after radical. Yes, thank you. All right. Just to review for the audience, life expectancy is a very important parameter to consider. With a negative evaluation for distant metastasis and pelvic reoccurrence, we're looking at EBRT or EBRT and ADT, right? With a pelvic reoccurrence biopsy positive, we're looking at EBRT and ADT or EBRT, ADT, or abiraterone. With distant metastasis, we're looking at EBRT and ADT, and EBRT and ADT and abiraterone. Can you scroll to the to the radiation screen for me again? All right. After radiation, in summary, again, life expectancy, a significant tool, but with a biopsy that is negative and a life expectancy of more than 5 years, we're looking at ADT. With a life expectancy of 5 years or more with a positive biopsy, we're looking at the following choices: radical prostatectomy with pelvic lymph node dissection, cryotherapy, HIFU or high intensity focused ultrasound, brachytherapy. With, again, life expectancy of greater than 5 years and a positive pelvic biopsy, we're looking at ADT, pelvic lymph node radiation, if not previously done, and pelvic node lymph node dissection. In both cases, you as the individual with a life expectancy of less than 5 years, you make your own decision, and this is a very personal decision that you make between you, your family, and your clinician. And a last shout out for clinical trials as they bring about the best possible care. I have any questions, Jerry?
Yes, I have one question here. My PSA has increased. What happens next?
Very good. As we said, your clinician has done the step one in terms of obtaining that PSA level. That clinician will then decide on any appropriate scan, and that can include the CAT scan, the MRI, the bone scan, or the PET scan. And then your treatment options would be laid out for you and your clinician and your family to make a decision on where to go. And I think it's important that we understand that these are decisions made between you and your clinician. Next question.
Next question. I had radiation treatment and now my PSA has gone up. Is surgery still an option?
Yes. Good question. Yes, surgery is still an option. The radical prostatectomy is still available. There were thinking in the past that that might not be an option, but we have improved the use of radiation, and so radical prostatectomy with this dissection is still a very viable option.
Okay, I have a third question here. You mentioned cure at the beginning of your talk. Is that really true?
Well, okay, yes and no. Okay, over the years, I've always said 95% chance of a cure if caught early. However, the truth is this. All right, we don't. Everybody doesn't get caught early. All right, so we're living with cancer. All right, and I think it's important to recognize that we remain vigilant with ongoing follow-up with that PSA, with a bone scan, whatever your clinician recommends, and we accept the fact that we are living with cancer, and we stay vigilant, and don't allow us to fall into the trap of kind of feeling like I've got nothing to worry about. You know, life has its twists and turns, and cancer survivors, we learn to live with the cancer diagnosis, no different than the patient that has diabetes learns to live with that diagnosis, or the diagnosis of hypertension, or any other major disease. So yes, if caught early, and as you hear, you heard from Mr. Farrington, 24 years. It's you can get comfortable in 24 years, but we are still living with cancer, and we must remain vigilant.
Okay, I have some questions also for you.
Go for it.
Okay, you mentioned, and this was very important for everybody to understand, there are a lot of tools that are out there for the treatment of prostate cancer. Okay, you mentioned surgery, but there was a term that you used, EBRT. Could you help the audience understand what EBRT is?
It's what I consider to be the first step in treatment.
But first, what is EBRT?
Can I pass that baton to you so I don't kill it?
Okay, external beam radiation therapy.
There you go.
Okay, so when you're thinking about the treatment, think about a flashlight. So flashlight covers a lot of area. So, and when you're thinking about an external beam, but also think about the new therapies that are like targeted therapies, like a laser pointer. So in your mind, when you're thinking about the treatments or the types of treatment, that external beam is kind of giving you a broader area of coverage. Proton beam therapy, which people have heard, is more targeted and focused. And then when you come to the targeted therapies that deliver radioactivity, it's like a laser pointer. Okay, but go ahead, Jim.
Well, I was going to, maybe you could help me. I hear a lot of patients talk about the gamma knife. What category, or is there such a thing as a gamma knife?
Well, what we want to do for the audience is keep it simple. So if you think of knife, gamma, targeted, or the radiation is very targeted or focused on an area. So you have radiation therapy, like external beam radiation, right? That's the broad area. And then if you have the concept of radiation of the gamma knife, that's a more targeted area. And so that's going to be treatments that are going to be localized to just small areas in the prostate, even people using that outside the prostate where they found maybe a small area of metastasis. So again, the way people need to think about it, you can either have a broad coverage of radiation, or you can have that targeted or sharp, narrow area of radiation. Everything else, and then what they can do is once they have this kind of concept in their head, then they can go and talk to their doctor. But everything else, we want to keep everything else as simple as possible. But a but allowing the patient to communicate effectively to the doctor.
And clearly, external beam has come a long way versus the day of the seeds, where we might not been able to control radiation as well. And our radiation therapists, they map that pelvic area with much accuracy. So external beam radiation therapy has really shown its effectiveness. Any other questions?
Okay, my question is this. When you talk about the 5-year life expectancy, is that 5-year life expectancy based upon the spread of the cancer? Or is that 5-year life expectancy if I'm 90 years old, I only have 5 more years to live? Where are we coming up with this? What is that 5-year life expectancy that you're talking about?
Is it possible you could bring up the FinPath website with the life expectancy table? We're talking about general life expectancy, not necessarily related to your diagnosis of cancer. So if you're 90 years old, I think you'll see on our life expectancy table that Finn has, there's a certain percentage that you'll live to 101, right? And so that life expectancy table takes in account any other chronic diseases that you're suffering from, diabetes, stroke, hypertension, any other illness that would affect your longevity. And so we use that a tool. Here you go. As we look at treatment options.
Now, what's very important here to kind of add on to what Dr. Smith is talking about is this. When you're speaking with a clinician or a doctor or healthcare provider, the first question is the validity, where did you get this information from? So we want you to know that when you come to FIN, you come to FinPath or FinPSA screening, FinPath treatment options, Fin trials, clinical trials. So break it up that category to remind everybody. The point is we use factual information. This information is from the United States Social Security actuarial life tape. So when the federal government or insurance companies are trying to determine how long you're supposed to live, if you just standard person in the United States, if you are, in your case, 71. So if you're 71,
you're looking at 12.9 years.
So I'm 13 years. I'll give that to you. So that's 13 years.
Thank you.
Okay. And now, but look at what we're saying here. That's 13 years, but that doesn't mean that's where it stops, because you could live longer than that. And especially those people who are being healthier, eating healthier, and monitoring and exercising, change their diet. All the things that will accompany survivorship has the ability to increase your lifespan. So I just put that out there. If you want a reliable source of information, then when you're thinking about treatment options, you're thinking about FinPath. And so we based it upon all that information that people will use to determine what your treatment options are.
May I have another question?
Yes.
Speaking of like, yeah.
Okay, my other question is this, clinical trials. Now, if I enter into a clinical trial, some of them, you're in the trial and they give you a placebo. You're not, are the clinical trials we're talking about here, if you go into the trial, we would get the medication or the treatment at that point, or is there a chance that we would get a placebo?
Well, see, first thing, I'm going to talk about your clinical trials.
Yeah, but he made me jump out of my chair, Dr. Crawford.
I'm going to tell you. And so the way I try to tell everybody is this. You're always going to get standard of care right?
Okay.
Okay. So if standard of care visually is 3 scoops of ice cream, chocolate syrup, some nuts, some whipped cream, the clinical trial will be 3 scoops of ice cream, chocolate syrup, nuts, whipped cream, and the cherry, or the new test, the new treatment that they're studying. So you're always going to get standard of care. And then what's interesting about clinical trials is this. What happens if you have a clinical trial and then they see that with the addition of this other treatment, there are certain trials will then allow you to participate in the successful component. So at a minimum, everyone needs to understand something about clinical trials. You're going to get your best care in a clinical trial, and you're going to get a standard of care. And I want everybody to understand what standard of care is, because that's the care that everybody else is going to get. If you look, we talk about NCCN guidelines, that's the care that everyone should receive.
I'd like to ask a question here. If you are diagnosed with progressive cancer, and you were, say, for 10 years or so, didn't have a problem. Now, clinical trials to me is like, you have no choice. I mean, if you don't do anything, you're going to die earlier. So you you have no choice but to take a clinical trial.
Again, if you don't mind me answer that, Jim?
Go right ahead.
You bring up a very important point. But the point that I would like to add, and which I'll get to when I discuss it, is this. You don't have to wait.
Right.
To participate in clinical trials until it's at the last stage. So, and just to transition over.
While you're doing that, let me just say this. If I have the opportunity to buy the Ford or the Lexus, I'm going with the Lexus. All right. And so clinical trial would be the Lexus. I don't have to be down and out for the very best care. So don't ever shortchange yourself. Dr. Crawford.
So before I start my talk, I just wanted to go back to further answer our visitor's question. So this is our fintrials.com site. Again, this is the information that's found at clinicaltrials.gov. And that's the site that publishes all the clinical trials that have been approved or that are approved for use in the United States and around the world. So, but your question was waiting until the end. Here, there are clinical trials for low risk. That's a person who may be in a watchful waiting situation, very low risk, not a lot of cancer, or there's, depending on your stage, if it's intermediate, high risk, if the disease is recurrent, then you have something that's non-metastatic castration resistant, metastatic castration sensitive, and I can better explain these terms if you need me to, and then metastatic castration sensitive. So every stage, there are clinical trials that are available. So you don't have to wait until you've exhausted everything. That's not what we want you to do. If you're diagnosed, you go to fintrials.com, and remember, clinical trials are part of your treatment options. They're not for you to pay for them. They're part of your treatment options.
Here's what I'm trying to say. I have no problem with what you're saying. All I'm just saying is that you have to do something. You just can't do nothing. Mm-hmm. You're guaranteed the fact that you go faster that way. So no, the clinical trials, I take my hat off to. Okay. I'll lay down on the floor to. Finn, as far as that is concerned, it's a blessing.
Amen.
It's a blessing. So that's where I'm coming from.
And what you're saying is right. It is a blessing because you're going to get the best care
Amen.
in clinical trial.
Okay.
So, any more questions?
Well, I pass the baton to you, Dr. Crawford.
Okay. So before I start, I just wanted to, what do we walk away with? We walked away with the fact that Dr. Smith has said that there's more than radiation and surgery. There are a lot of tools that are available. And really, when you think about these tools, these are tools that are imaging tools that you need to be familiar with. And there is the PSA test. And why is this very important is because this is kind of basic or the fundamental biomarker that needs to be followed, especially when we're talking about the management of survivorship. So I wanted to, Jerry, can you put the slides up? Okay, next slide. So this is a simple picture, and this is a very important picture because there was a time when we were dealing with prostate cancer. You only really had radiation and surgery and a chemotherapy. That was it. But now we have so many tools
There you go.
in the tool chest.
Yeah.
And then it's not just one by itself. It could be a combination. It could be taking the taking the treatment and before surgery. So you can add an ADT or a next generation or therapy before, during, and even after you have a surgical procedure. So there are a lot of tools and a lot of options that are available. This comes from people participating in clinical trials. And that's extremely important for everyone, especially for Black men to participate in clinical trials.
Amen.
So what do you want to say about clinical trials? The question came up, standard of care. It's not a placebo. So what you have to remember, that was a very important point. You're not getting a sugar pill. What you're going to get is standard of care. And those are what everyone would receive who have your diagnosis, standard of care. And like I said before, that clinical trial is just like the cherry on top of that standard of care. Right? There's something else. Well, why should you participate in clinical trials? This is almost like concierge medicine. Right? Concierge medicine. You're going to get the best care. Why is it the best care? Because it's not just one clinician, one healthcare provider that's monitoring your care, but it's multiple people. And then it's not just healthcare providers. It can be people in the community who are asked to sit on the review board to take a look at the treatment, the protocol. This is the guidelines for that clinical trial. So you got a lot of eyeballs on this trial because they want it to be successful. That's why it's kind of considered to be a concierge-like care. And then what we're finding is that there's no cost because the sponsors of the clinical trial will normally cover all of the cost. And there's certain situations where there may be some additional costs incurred by the patient, but even having the opportunity to ask for help with covering those costs. So do you think that you need to stay in Massachusetts if there's a clinical trial in Providence, in Rhode Island, or in New York, or in Chicago? Because some of these clinical trials may cover transportation costs, housing costs,
some miscellaneous stuff, food. Even if you drive from Western Mass into the Dana-Farber Cancer Institute and you're participating in a clinical trial, they'll cover parking and gas. They want you to participate in the clinical trials. Now, and what else do we know about clinical trials? There are 4 phases. And 1, 2, 3, 4. Because the first phase, they're really trying to get a feel for how well the drug works, its safety. Does it cause a lot of problems? Is there a lot of side effects? They want to see how it works with the patient. Now, and that's the general category. To the majority of times, they have an idea of how it works because they've done years and years of research in a non-clinical study in an animal model. And so what they want to do is now when we move it from an animal model into the clinical setting, then we're in phase 1. Then phase 2 is really to kind of feel on dosing and seeing how well, because we know that the patient tolerates it, but what's the best dose? Then once you figure out what the best dose is, then they have a significantly larger clinical trial. It'd be hundreds to, if not thousands of people. If you look at you've read how many people participated in COVID clinical trials. Thousands. And they're still participating in these clinical trials. So what we want you to do is understand that there are 4. And we want you to understand, as I mentioned before, depending on where you're diagnosed, this doesn't mean that if you have to be treated and then the cancer comes back, because there's a clinical trial for someone like that, but also if you were just initially diagnosed, there's a clinical trial for the initially diagnosed individual. So I wanted to say. So we always want to leave you with this. NCCN believes that the best management of a patient, of any patient with cancer, is in a clinical trial. And we believe this, and the NCCN guidelines, National Comprehensive Cancer Network, the group that's responsible for crafting the guidelines that the healthcare providers follow for the treatment of a wide variety of cancers, especially when we talk about prostate cancer. Say this. This is not just Finn saying it. We're just conveying that message to you that a reliable source of people, specialists in the area, are saying this. Next slide, Jerry. So what I'd like to do is, so we wanted to tell you, we have Finn, and I'll show you afterwards. We have FinnTrials.com. Now, FinnTrials.com, basically, each month, Finn staff, we sit down and review all the actively recruiting clinical trials. And I said before, there's 4 phases between phase 1 and 4. Any one of those trials that are actively recruiting, we take them and place them in a bucket that reflects whatever your diagnosis is. So if you've ever been to clinicaltrials.gov, that's completely complicated. We took that out of it. We're going to take it, we're going to identify it, we're going to put it in the bucket. So all you need to do is walk away with knowing what your diagnosis is, right? So in this case, as we review these clinical trials, we always identify some things that we'd like to put on our spotlight. So each month, during our managing survivorship meetings, we're going to spotlight a clinical trial that was interesting. Now, we're not going to spend a lot of time on it. It's going to be in our recordings. It's going to be on FinnTrials.com. And then you'll have the opportunity to go back and look at that trial even further. And something that you will find that other groups don't do is, even if you look at the clinical trials, if you give us a call and you need some help, we'll help you understand the clinical trial, help you effectively communicate, even with the sponsors. We're here to help you. So in this one, this is called the Libertas. clinical trial. And again, this number of NCT number, that's the number, that's the code. That's the code that people, if you type it in, whether it's in Google or if you type it in at clinicaltrial.gov, it'll take you to this clinical trial. So I just put some information that's on the clinical trial site. We know that this is an ongoing phase 3, right? Prospective, randomized, open-label, multi-center global study. Complicated. But the only thing I want you to walk away with is the phase 3. It's ongoing. And then at the bottom, there's a term I wanted you to understand, because they'll be throwing these around. Prospective means it describes studies that start now and look forward, and they're designed to gather information. That's what this study is supposed to do. And they're focusing on collecting and extract and exact details that you need, and often resulting in more complicated and successful data. So when we look at this summary again, it was phase 3. It's prospective. It's evaluating Erlita, right, apalutamide, with intermittent versus continuous ADT following PSA response in patients with newly diagnosed metastatic castration-resistant disease. And another thing about this, and this is interesting, why? Is because what they want to try to do in this clinical trial is figure out, do I need to take this chemotherapy, this androgen deprivation therapy every single solitary day, or could I break it up and give the body rest? And that's why I said, the companies are out there that are creating these studies that kind of fine-tune, personalize your care. That's important. And then something that's very interesting in this clinical trial, and this may receive the first of its kind when we start talking about clinical trials in the United States or in the prostate cancer space, they're looking at recognizing that genders, people may consider themselves a different gender, but if you have prostate cancer, they're not worried about your gender. They're worried about whether or not you have prostate cancer. And so they want everyone to participate. Next slide, Jerry. Now, remember what we said before. Before there was surgery, radiation, and then there was chemotherapy. Now, since everybody understands, since COVID, we've learned a lot of immunology, vaccinations, antibodies, and the antibodies attacking the virus, that type of stuff. But what's very interesting, and I may pronounce this wrong, but there's this interesting clinical trial called, it's AMG 509. Again, there is the NCT number, that's its ID, right? And the drug's name is xaluritamab, okay? So we'll just say 509, AMG 509. Now, what's interesting about this is, and which I didn't mention before, is also the treatment was looking for. Jerry, go back a little bit. I didn't mention this for that Libertas clinical trial. Okay, good. I did. Okay, it's a trial. The diagnosis for this trial is metastatic castration resistant. So if a person has metastatic, where the disease has gone outside the prostate to different areas of the body, they receive treatment. I said not resistant, it's just sensitive. So metastatic castration sensitive. If the cancer has gone outside the prostate and it's in different areas of the body and it's sensitive to the cancer, to the treatment, to hormonal treatment, then they want to see whether or not you can have the body rest. So I just wanted to bring that out. It was metastatic castration sensitive. Next slide, Jerry. So let's look at this AMG 509. So we know it's a new treatment for advanced prostate cancer. But this is a targeted cancer treatment. It uses the fundamentals of the antibody or immunology to to enhance the immune response. So we know it's designed for metastatic castration-resistant patients, right? And it looks for a protein that's found on the surface of the cancer. So say, for example, and this is kind of an odd analogy, if you had a bunch of white lights on a Christmas tree, and they're small, you could see all these little spaces where the white lights are. Well, what happens is they've created a tool where, one, if you have the protein and you know what it is, you can kill it, the cancer, because if the protein is specific to your prostate cancer, then you could target or deliver a molecule that binds to it. Now, what's interesting about this is they're not using a chemical or radiation. They're doing something else. So envision something like a beehive and bees concentrating around the honeycomb. What happens if you can bind to the cancer, but as you bind to the cancer, you bring one of those T cells, those immune cells along that kill the cancer. So you can concentrate all of the immune system's killing ability around the cancer, like bees around the honeycomb or bees attacking. So they focus on the cancer. This is what is important. So what it does, it's a molecule like an antibody. It snatches onto the surface of the cancer, and as it snatches onto the surface of the cancer, it drags one of these immune cells that kills the cancer. So you have direct contact between your immune system, that killing cancer cell, and the cancer. So next slide, Jerry.
Why can't you, without this special ingredient, and you say it takes you, it pulls your immune system to kill the cancer, why is the body immune system not destroying the cancer naturally?
Well, see, so, I mean, that's a very important question. A large percentage of cancers begin to occur or escape the immune system because as you get older, your immune system doesn't work as well. It needs a little help. Okay? So, say, for example, in your house, and I'm saying your house has termites, but if you had a couple of termites in the house, now you can kill them, that's it. But if you had millions of termites in the house, it would be very difficult for you to control that destruction of the house or that area. So what happens is, the immune system, as you get older, doesn't fight as well, and it needs help. You need help turning it on. You need help getting as many cells around the cancer, the immune cells around the cancer as possible so it can kill. The higher the concentrations go, that was an excellent question, because the higher concentration of the immune cells around the cancer, the better you can kill the cancer. But if you can't get the immune cells to the cancer, then you can't kill it.
Gotcha.
Okay, so now this next one is extremely important. Now, this is not a new treatment option. Now, this is an immunotherapy. But guess what? This immunotherapy is a immunotherapy that uses your own immune cells. So it's called autologous. It's called yours. It's your cells. But what they do is they take this dendritic cell or cell, immune cell, and they take it outside the body. They culture it in the laboratory with something that triggers the immune system, and then they put it back in the body. But you know what's interesting about this? Is because this isn't new. If you go back like 2003, I mean, that's about the same time FIN was established. So 2003. And what they found out is in 2003 that this treatment option, immune treatment option, worked. But you know what they didn't know? Because there was not a lot of Black people participating in this clinical trial, they didn't know how well it worked for Black people, for Black men. So it took 7 years from 2010 since its approval to 2017 to figure out, oh my God, this works extremely well for Black men. It's a more precise, a more personalized treatment for this group of people. So now fast forward from 2017 to 2024, and I flag this because for those of our viewers who are in the Connecticut area, Hartford area, this is a clinical trial in your backyard. It's already known to work in Black men, but they're adding a little bit more. So in this case, that standard of care was the immunotherapy. And the clinical trial is the immunotherapy plus an ADT. Now, what's interesting with this clinical trial is this. What they're saying is they call it bipolar, okay? Bipolar antigen therapy. So what they're doing is shutting down the testosterone level and then flooding the body back with testosterone. So it's like taking a bag of ice and going bam, 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 and shattering that off and on mechanisms causes DNA damage and causes the cancer to die. Now, this is an immune cell that collects those dead cancer cells and then turns on the immune system. Very unique. So I just flagged that. So, you see what they're doing now? They're taking proven technology and now combining it with some of the new stuff. That's why we have to participate. So next slide. Now, again, I talked about the AMD 509. And it's called bispecific concept. This is where the molecule has the ability to bind to the cancer and then to the immune cell and brings it together. This is another one of these things. So those people who live in Texas at MD Anderson, there's this clinical trial where they do the same thing. It's binding to, again, a protein that's specifically found on the surface of the cancer, PSMA. Now, this is important for everybody to understand. I didn't say PSA. I said PSMA. So that's prostate-specific membrane that's on the surface of the cancer cell. Yes. Antigen. Yep. And it's very important for everybody to start remembering there's a difference between the two, because now we have diagnostic tools, imaging tools that can light up cancers by using, again, a molecule that binds to that PSMA. And the PET CT scan, which Dr. Smith talked about, these imaging devices, right? Lights up the cancer. So the concept here is you can't kill it if you can't see it. We're now in the 21st century, where now we can see where cancers are located, not broadly, or small areas in the lung, in the liver, even in the brain or in the back, because we're able to target those specifically. So this, again, this is out of the Houston area at MD Anderson. And what this trial does is they have a compound they call, it's like Regen 5678. That's just the number. But what they're looking at is the PSMA is a protein found on the surface of the cancer. And this CD28 is just a protein that's found on the surface of the T cell. And what I said before, the T cell can kill. So if you concentrate those, because as you get older, the number of these immune cells that are able to concentrate around the cell decreases. And now you're able to bring these two, cancer plus the T cell together to kill. That's perfect. So these are things, and what we try to do moving forward is as we curate, as we go through on a monthly basis to look to organize the clinical trials for you, we're going to try to give you an idea of what's out there. We're not trying to tell you to take advantage of one or the other, but we want you to know that they're out there. So when you go to your doctor and your healthcare provider, you want to get them, you want to start talking about clinical trials as part of your treatment options also. So does anybody have any questions?
Yeah, I like, I've been hearing something about what they call, oh, geez, stem cells. I heard that this was tried on a person who had, it wasn't prostate cancer, by John Hopkins on a woman who had cancer in the head. And they used polio cells, and that destroyed the cancer cells.
So the
It's
point,
interesting.
so the point is, you see what you just example, that's just another example of how clinical trials are being used. Now, I personally and our staff personally haven't come across anything like that in the clinicaltrials.gov for prostate cancer. And then on our database, we haven't come across anything like that. But there are some unique combinations of therapies that do exist. So we want everyone to remember clinical trials are part of your treatment options. And we have organized clinical trials in a fashion that's easy for people to understand. And lastly, if you're still having problems, you can pick up and call Finn. Right?
Right.
Okay. Jerry, I'm finished. So, any questions? You have our tag team is up. So we can field questions, whether it's recurrence of disease and treatment options or clinical trials.
Yes, I have a question.
Oh.
On a clinical trial.
Well, we have one. Can you get the mic? And Jared, wait a second. Oh, Mike. Okay, wait a second. Jerry, go ahead and ask your question. Jerry, ask your question.
Okay, I had the robotic surgery in 2013, but my surgeon did not inform me that my margins were not clean. And in 2023, I noticed my PSA started to rise again. After evaluation, I had to have 36 radiation treatments, and now I see the oncologist every 6 months for blood work. The PET scan was negative, so I was treated anyways with radiation therapy. That seemed like a story.
What we do recognize is that clinicians, and this is an educational segment of FIN, disease will come back. But remember, now we have these new tools and these PSMA PET scan, because I didn't hear that the person mentioned the PSMA PET scan. That's going to give more data, more information about what your treatment options are. So remember, we're on a prostate cancer journey. And survivorship is about monitoring it and making sure we can identify a return of the cancer early so we can take full advantage of all the treatment options that are available now. Jerry, next question.
Are there clinical trials for low-risk patients?
Yes. So there are clinical trials for low risk. If you were to go, and since I don't have it up, but if you were to go to fintrials.com, you will look, if you scroll down, you will see that we've broken it up into different categories. And you will see low risk, intermediate risk, and high risk. You'll see those there. And all you have to do is click on that button and it will take you to this large number of trials that are there. So if the person had asked the question, once the meeting is over, and they can go to fintrials.com press on the low risk button, and you'll see all the actively recruiting. It's not all the clinical trials there. It's all the actively recruiting clinical trials between phase 1 and phase 4. Next question.
Actively recruited for prostate cancer.
Actively recruited for prostate cancer.
Next question. If you sign up for a clinical trial, how often do you need to report to the clinic that is conducting the trial?
That's an excellent question. And it will depend upon the type of clinical trial that you're participating in. So you could have a clinical trial, let's just say it's an exercise diet clinical trial. And in this clinical trial, where someone would come in, right? They can set you up with exercise equipment in your room, in your place, and you have to do an assessment at the end and an assessment at the beginning and assessment at the end. That's a clinical trial. So it depends on what you want. You may have to do it every month. And a lot of the ones that are looking at cancer and metastatic castration-resistant cancer, some of the advanced treatments, are going to want to treat you. They're going to watch you for maybe a day, and they'll cover these costs, and then have you report back in a month. But it all depends upon the clinical trial that you participate in. And clinical trials range, like I said, from exercise to diet to intervention or treatment of the cancer. Next question.
We should go to the next one.
Okay.
What is your opinion about using Extendi?
Well, I can't give you an opinion on it. We can give you information and to help you better understand its use. But what I wanted to do is that we've talked about recurrence of the disease. We've talked about clinical trials as being a part of your treatment options. Now we want to hear from 2 patients. We want to hear their story. Barney?
Hello, yes, I'm here.
Could you come on?
All right, I need to turn on my camera. Okay, can you hear me?
Yep. And this is very important because there's something to say here, and I want both. We'll just go with Barney first since he's on the screen.
All right, thank you, Dr. Crawford.
Barney, can
yes.
you tell us how many years, how long a survivor are you?
I was initially diagnosed in 2004. So I'm coming up on 20 years in September.
So I want everybody to understand that. That's 20 years and 2 decades. 2 decades. And so, can you tell us your story?
All right. Again, I was diagnosed in 2004. When I was initially diagnosed, I didn't have any symptoms, and it was discovered through a routine physical examination where my PSA, prostate-specific antigen, came back elevated. It was confirmed as prostate cancer and bilateral in both in 2 lobes. I chose the radical prostatectomy based on the research that I did on my own at that time. In 2004, there was almost no information when it came to Black men less than 50 years old with prostate cancer. I wish I had FIN back then. And the reason I chose the surgery, because at that point in time, the rule of thumb was if you had a reoccurrence, then radiation would be an option if you went with surgery first. But the reverse of that, the opposite of that, was not true. Now, as we heard earlier from Dr. Smith and Dr. Crawford, that has changed. The radiation treatments have improved, so now surgery can be an option after radiation. Anyway, that's the reason I chose that. Had the surgery, was doing fine. Then at about the 12-month point, my PSA started to double almost every month. It went from 0.2 to 0.4 to 0.8 to at that rate. Here's where it gets interesting. We see from now the NCCN guidelines that radiation It would be the standard course along with hormone treatment. The treating oncologist at that time called me at home one day. I was getting ready to go in for radiation, and he called me at home and told me that, they had discovered that my cancer had metastasized to my skeletal system. And they based that information on an MRI. We had detected an abnormality in my upper right trochanter of my right hip. What they didn't ask was, had I had any injuries? But based on that limited information, the decision was made not to proceed with the radiation and to go down the hormone treatment. I didn't agree with that. Sought advice from another oncologist who agreed with my position that, maybe it has metastasized, but what you have to do is some more analysis, i.e. a biopsy of that area. And I insisted on having a biopsy of that area, and it came back negative for metastatic prostate cancer. So, and I say that because, mistakes can be made. Had I gone down the road with the hormone treatment, I wouldn't be talking to you here today, more than likely. So I had the radiation treatment, a series about 7 weeks. I had the external beam radiation. And since that point, I've basically been undetectable since then.
So you see that? Now, let me ask you a question.
Okay.
Detectable. So what do you do every year?
Once a year, I'm in what we call now the survivorship program at Moffitt Cancer Center. Every year, I go in and have a PSA test. And it usually, thus far, it's been coming back negative. But if for some reason it does come back and starts to, the velocity starts to increase at a rate which is indicative of a reoccurrence, my next course of action would be to seek a clinical trial. But once a year, I go in for a PSA test.
You see how important that was? So what we're seeing is, now you're seeing a person with prostate cancer who is a 20-year survivor. And in survivorship, a key tool is this biomarker, the PSA protein.